So this is the fourth case of the day from Bicêtre, and then we'll go to Toronto. This is a 48-year-old woman. She has a very important past medical history with high blood pressure and Sjögren syndrome, which was really a matter of problem for this patient, especially for the general anesthesiology. So she was found this right MC aneurysm, incidental aneurysm, and conversely to what was seen on the angio-MR, there is an MC aneurysm which has a very irregular shape, and as well you have another very small aneurysm which is the origin of the bifurcation. So this is the 3D view of this 48-year-old woman. And we were quite surprised about this very small aneurysm, which was really not seen on the angio-MR. So these are the different measurements of this aneurysm. It's roughly 6 millimeters in the largest diameter, quite small neck. But the main problem, it is this small aneurysm, which we have to admit looks a little bit ugly. These are the diameter of the vessel, which is more or less the diameter of M1 segment, which is around 2.5. Oui. So this is the plan. So Jacques will probably explain. We'll first perform probably a balloon test occlusion. So the high-perform balloon will be placed in M1 segment, and they will be injecting the ICA to see what is the potential supply from the anterior cerebral arteries through the pile network through to one of those two branches in order to decide in which branch we should place the flow diverter, because we have decided to place a flow diverter. So the base camp is the long sheath from Stryker, the Infinity, 90 centimeters. And they will be using a distal access catheter, which is the Phenom Plus, 105 centimeter. So this is the high perform that they will be using for the balloon test occlusion. They will be using the Phenom 17, which is a 17 microcatheter to coil the aneurysm, depending of the result of the balloon test occlusion. So Jacques will explain you the philosophy of that. And if they will place the pipeline either in the upper branch or in the lower branch, if you deliver in the lower branch, then you will cover this one, and you have to be more or less sure that there is a potential supply to this branch. So now we are going back to Bicêtre. So you have Professor Jacques Moret, Marta Jacobucci, and Thibault with our new resident. So Marta is from Rome, and she's working with us for 3 years now. Jacques, can you hear us? Can you listen to us? You are now on screen in
yes,
hello?
I hear you. If you hear me, it's fine.
Yeah, it's okay. Can you explain where you are now?
Okay, so the very first thing is we decided to put a flow diverter in a bifurcation to emphasize, the discussion. So as you can see, this aneurysm has a daughter sac just at the base of the aneurysm, right at the origin of the upper branch of the bifurcation. The decision was taken to treat this aneurysm with a flow diverter, understanding the potential PL circulation. In order to do so, we delivered the balloon catheter in the A1 segment, protecting the A1 and protecting the bifurcation, because the bifurcation free is a way to aspirate as much as you can, and you clearly understand the potential PL circulation. So, as you can see on the screen, AP view, the balloon is occluding the M1 segment. The collateral flow from the anterior circulation is visible, And you can clearly see that on the lateral view, you have a very good refilling up the bifurcation.
Jacques, we don't have the lateral view, but I will display it. Okay, I think we'll have it now.
Lateral view.
Yeah, okay, we have it now.
So now you have the lateral view. We come back, and you can see that the posterior frontal, pre-Rolandic, and parietal area has a good PL circulation and retrograde flow, indicating that you can cover this Rolandic and parietal branch because of the collateral circulation, which is definitely much easier for us because going in the lower branch is easier than going in the upper one with a flow diverter. Nevertheless, in order to give the chance to this aneurysm to be treated as soon as possible, due to the fact that it's an indirect flow diversion for that aneurysm, we have decided to put a coil in the sac of the aneurysm to induce a better thrombosis and a faster thrombosis of the sac. So the first thing that we are going to show you is we put a coil without any protection of the neck, trying to avoid the bulging of the coils in the origin of the branch. And when the first coil is delivered, we move down with a stent. So the measurement that we got from the Siemens cure, can you see the Siemens cure measurement on the lower side? Yes.
Yes, we have it.
So it's okay. So it's perfectly done in order to not cover the bifurcation of the lower branch of the middle, but also to avoid the coverage of the origin of the lenticulostriate artery trunk. So doing so with a compression of 20%, we decided to use a 2.5 millimeter, 10 millimeter length pipeline shield. So that's what we are going to do. First, I put a coil in the sac. Second, I put the stent according to the information I got from the Siemens cure.
Okay, Jacques, perfectly understood. Let's go working. The day is not finished for you, and we'll be managing. So just to summarize the situation, they place a balloon in the M1 segment, injected the dye, and they have checked that this upper branch is potentially supplied. So the initial plan will be respected, that they will place a flow diverter covering this upper branch, because if there is an acute thrombosis on this branch that will be covered, there will be a potential supply of this branch. The only thing you should avoid is to have clotting problem in this covered branch. So this was an issue. It has disappeared a little bit since now we are using a conjunction of ticagrelor with aspirin, which has decreased the thromboembolic complication we got within this covered branch. So we have decided to use a pipeline just to get rid to this small aneurysm. And because this larger aneurysm looks a little bit ugly, irregular shape, we have decided to coil this aneurysm. If it was regular shape, probably we would have not treated selectively this aneurysm, and it would have shrunk over time. So what was given through the, so this is the progression of the, here, this is the progression of the 17 microcatheter. So it is a 17 phenom from Medtronic, and they deploy an axiom 4 in diameter by 8. They will not try to have a complete occlusion of the aneurysm, but before they shut the door here, it's better to place some coils. Of course, they will not touch the small aneurysm. So using the pipeline, the goal was as much as possible to avoid covering some side branches. So this is why they will avoid to cover this lower branch from the MCA bifurcation. And as you can see here on the 2D, there is a very large lenticular striated artery, and we want to avoid covering it. So the length in between those two potential targets not to cover has led to choose pipeline 2.5, which is the smallest in diameter, and 10, which normally should fit, I hope, without covering this lenticular striated artery. So for sure, we expect having a shrunk of those two aneurysms over time. So this is a control angiogram. I will a control angiogram after the placement of the first coil. I will show you here the non-subtracted picture at the same time instead of having a black. So this is the subtracted view. So we frequently use this digital magnification, which is very useful. So keep in mind how useful is this magnification. This aneurysm measures 6 millimeters. And when you display that in the Louvre, the height here is 6 or 7 meters. So you see that the quality of the picture allows a very nice enlargement of the picture.
Would you use a smaller, softer coil for the center? Jacques said he was going to put only one coil.
Laurent, I have one.
Okay, so they decided, this is a comment from the Angio Suite, they decided to use a distal support with a Phenom 27. So it's not possible to have injection of dye through the Phenom 27 when you have a 17 microcatheter within it. So you see here the Phenom. And so they have to inject the dye through the infinity long sheath, which has a larger lumen. So this is probably the second coil.
Oh non, il a enlevé le cathéter.
Il a enlevé le micro 4.
So they just introduced the Phenom 27. So this is, they will stay only with one coil.
So Laurent,
So they are a little bit trapped with the length of the material. You know, nowadays when you have a triaxial system, you are always trapped with the length of material. So you are stuck here with the Phenom Plus. They cannot they cannot navigate the infinity to distal because otherwise they get a vasospasm. So this is why the Phenom Plus is not navigated that distal. So this is the Phenom Plus here because the infinity is remaining inside the common carotid artery. So they were expecting to have it more distal, but it was not possible. So as you have seen this morning, it's possible nowadays to transfer directly the 3D volume directly to the workstation for the Siemens size software. So it's very easy nowadays. And it's possible also to display whatever is the source on the Flex Vision, external sources, internal sources. So what's the beauty of the simulation? It allows you to have exactly in front of your eyes the simulation in order to try to reproduce live what you will be doing. So this is the Phenom 27 over the Avigo 14. So of course the guide wire is always going in the bad direction. This is a stepwise effect, discrepancy between the size of the 14 guide wire and the 27 microcatheter.
maybe you go to the
So you have to navigate first the wire a little bit more distal to straighten the structure in order to allow the navigation of the 27 catheter.
Laurent, can the panel ask question or not?
Yes, please.
No, I have one question because I fully understand what was Jacques doing with a balloon to check the collateral circulation, blah, 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 blah. But in that case, you know, the neck of the aneurysm is on the upper branch. So where is the logical not to put the flow diverter in the upper branch? Why? At the end, I have the impression you just put the flow diverter everywhere, somewhere in the bifurcation, and that's okay, it will cure the aneurysm. So can you...
I was expecting that somebody would ask the question. I'm disappointed that it's you asking the question.
No. You told me I am invited because I am stupid, no?
So, okay. So I remember the aim of a flow diverter is to divert the flow. You understand this point?
It's a very good message for everybody. Huh? A flow diverter is to divert the flow.
So the small aneurysm is placed really on the bifurcation. It's trickier to navigate in the upper branch here, and this one is easier to navigate the flow diverter. Here it's more complicated, and you have a discrepancy in the diameter between this branch and the M1 segment. Technically speaking, it's much easier to place a pipeline here,
yes,
as far
yes.
as you are sure.
Yes, but it's not a sufficient reason to put it here.
So when you will be covering this branch, everybody knows that you will have a decrease in the size, which will lead to the complete occlusion of this branch over time. And you will have a delayed occlusion of the aneurysm over time, and we expect to have the delayed occlusion not only of the large aneurysm, but also on the small aneurysm.
So, but then, Laurent, this is something that you do for every bifurcation aneurysm. You do test occlusion before to decide on which branch you're going.
Most of the time, this is what we do. Yeah. How do you calculate in which branch you can place your flow diverter? Because this is the problem. You can never be sure that the diversions that you will induce in the branch will not lead to any kind of acute thrombosis on that branch.
Usually, I would say in most of the cases, you place the flow diverter in the biggest branch, in the one which is straight, and so most of the cases it's a posterior branch, and which is the biggest one, the biggest territory. So I prefer to cover the upper branch. So we almost always go in the inferior branch and cover the upper branch. And technically, it's much more easy to do as well, indeed.
But you are not more comfortable to know that if you have an acute thrombosis on that branch, you will have a collateral supply to this branch more than for the upper branch, the lower branch.
I'm not sure you can really trust the test occlusion because you occlude the M1 completely, that it's not going to be the case at the end, so, and you didn't check the posterior circulation. So I'm not sure it's useful, and we don't do it indeed.
Laurent,
so it means that your recommendation is to do a test occlusion in every branch of the bifurcation?
Yes.
No, it's what Chris was saying.
To not do any test occlusion.
So just we can continue the comment. I just want to for you to understand. So the phenom 27 is in place. The pipeline is arriving. Most of the company, they provide a too long distal wire. I don't understand really why. So you see, you have to release the tension in the system. You see that the phenom is completely, you have no tension at the level of the carotid siphon, because of course you have to push the wire. So I don't foresee too much the interest of such a long wire. So you have the sleeves which are attaching the distal end of the pipeline. So you have to continue to unsheath. Now it's opening. So you have to keep an eye on where you want to land. So of course there is a straightening of the anatomy. So you have to do another control angiogram to be sure that you are landing exactly where you wish. So this is the control angiogram. It's not completely open, but it looks to be properly placed.
I think it's perfectly placed to not go towards the deep temporal branch because you haven't overflow diverted the deep temporal branch.
Yeah, I think
So it stops right there.
very well positioned. And also, like when you start to deploy the stent, it will foreshorten a little bit. So it will definitely like start there when it starts to push it forward. Now, I think it's also a very good idea to put that coil that he placed. I mean, that aneurysm does have a fairly small neck. I mean, the main problem is that other like daughter sac or secondary aneurysm or whatever you want to call it. Now, I agree that, you know, when you have like such a difficult angle, like, or with this like lobulation on that upper branch, I mean, that makes it more logical to just place the stent in the lower branch. But again, remember, like, there's a lot of like data, including some that we have published, like 2 or 3 papers in the past, that tells you that the smaller bifurcation areas, they take longer to close when they do. And when there's like a lot of inflow from like that upper branch, for example, as was pointed out, that aneurysm is truly like a superior division aneurysm, not a true bifurcation aneurysm. That may keep that aneurysm patent. And even if you tell you, oh, there's flow modification and, you know, those aneurysms will never rupture, I mean, we really don't know that in the long term. So that's, I think it's a good idea to put a coil there.
So the distal end of the pipeline is okay. So then, as all kind of braided stent, you have mostly to push on the pusher more than to retrieve the microcatheter. For all the flow diverter, this is the marker beyond which you can't resheet the pipeline. And this is the proximal marker of the pipeline. Of course, everybody is looking here, but the most dangerous is what's happening here, because there is a... Okay, it is detached, probably.
He's recapturing it.
Okay, recapture.
I think it actually moved.
Yeah, it moved.
slightly back.
Yeah, it moves. It has moved.
Stress testing the bleb.
Laurent, the simulation that you have would have been good one to see which of the 2 branches to choose. You know, that simulation to see what the flow diverter does.
So the simulation provides you 2 information: the length of the flow diverter,
Right.
depending of the compression, and also the wall position. It will give you if you will have a good wall position. So here you have in the green color, it meaning it's not possible to read, but it means that you have a pretty good wall position. So then you have a mesh density. You have to change the scale by pushing on that button, so they didn't push it. And depending on the compression, of course, you are increasing the porosity, decreasing the porosity. I never know. I mean, you compress and you have the porosity, which is decreasing. So with this, you only simulate those things. You don't simulate the flow itself.
Okay. And the other question in this particular case to Adam, you have this case, would you do endovascular? Would you clip this? Non-dominant hemisphere, MCA, small, pointing there, he's got that little daughter, which is problematic.
You know the answer.
So
Laurent says he's here for stupid. I'm here because I'm the dumb American Neanderthal surgeon. So in a 48-year-old with Sjögren syndrome, it's a very easy, simple craniotomy, very, very low risk. I would treat this with surgical clipping. Maybe when I am more evolved in the future, I'll do this kind of thing. I find it very interesting, but in my center, this would be a mini craniotomy.
Alan, what would you do?
Yeah, I'm learning something about test occlusion for.
It's anatomical. That was anatomical.
Yeah, but I would favor clipping this aneurysm myself.
You could clip both of them, huh? the big one and the very small one. You could clip him. The clip will not sleep.
2 clips.
You're not narrowing the inferior branch.
No, we have very small clips, 1 millimeter clip on that, and then probably a fenestrated clip overlapping it on the larger aneurysm. That's one of the advantages of open surgery.
Because it looks more like a blister-like aneurysm, no? Which is supposed to be very difficult to treat. It's a very, very small aneurysm.
No, it's a small bleb. Yeah, blister, I prefer that we reserve it for dorsal carotid rupture blister aneurysms.
Okay, you can see that now it's properly placed. Continue to push on the pusher to deploy the pipeline. They have the simulation in front of their eye, so they know exactly how to properly place the pipeline. So it is still attached, and now it is released. Okay. So this is the proximal part of the pipeline, the distal part of the pipeline. So now, just a few minutes, you will have the control angiogram.
So Laurent, let me ask you something. You did an M1 test occlusion to look at collaterals from the anterior cerebral artery to the upper division.
Let's have a look to the angiogram, and then we'll be having all the comments you wish. Marta, can you remove the subtraction, please? Can you remove the subtraction? Can you enlarge the picture, please? Jacques, can you enlarge the picture? Okay, go back and forth.
Subtract, non-subtract.
Advance. Okay.
We are just at the origin of the lenticular striate and just at the origin of the bifurcation. It could not be placed better.
Congratulations.
Okay.
As far as nobody is thanking me, so I am thanking myself. Thank you.
Thank you, Jacques, Martin, and Thibault, and that's a good job. So it's a way to treat bifurcation aneurysms.
So we do the VASO-CT now.